Hi dentists, how are you? This is Muhammad Musa from AFK Study Plan. Today we're gonna continue what we started about the articles from the NDEB website. Today we're gonna cover the pulp therapy for primary and immature permanent teeth. These articles are important because they speak about terminology that we know before, but they have different indication. And in our culture or our study, we have different indication for this, and the guideline for this has been changed more than once recently. So I'm giving you the recent one, 2020. This is the latest version in the NDB website. As usual, get your notebook, your pen, write your notes down. Make sure to do your best to answer the questions, which will appear in your screen every maybe 10 or 20 or 12 minutes. And with that all being said, let's dig deep to it. Before we started, there is some terminology that we should be familiar with so we can know about the stuff here. And this is a different article in the list. It's a very short article, just one page, giving you the terminology. So for our endodontic diagnosis, we have two separate entities that we should address: the pulpal diagnosis and the apical diagnosis. They are, we can say, not totally separate from each other, but they are independent in a way. Which meaning, like, so for pulpal, we have normal pulp. Normal pulp is a normal thing. Patient has nothing to complain about, symptomatically free, normal response for pulp testing, everything is good. But when patient have a caries in the tooth, and this has been going for a long time, maybe 6 months, maybe 1 year, maybe 2 years, depending on the patient hygiene and his diet, so he's going to have pain, which we're gonna call it as reversible pulpitis. When we're gonna call this, depending on the subjective and objective finding from the patient. But in this category, inflammation should resolve and the pulp return to normal, meaning the pain is not lingering, he's not waking up at night about the pain. If he take a painkiller, it's good for him. Everything is, he has pain, but not a severe pain. And then if the patient didn't go to the dentist and he leave this tooth and the caries is going more deeper into dentin near to the pulp, he might go to the next category, which would be symptomatic irreversible pulpitis. In this one, the pain will be lingering thermal pain, sometimes spontaneous pain, or sometimes it will be referred to other parts in his head. And then if the patient didn't go to the dentist at this point, it will be asymptomatic, because like the body would not like to be in a stress for pain for a long time. So the body trying to get rid of this. So the tooth will still be vital, but vital inflamed pulp is incapable of healing. So starting from here, we cannot go for vital pulp therapy. Additional description may be no clinical symptoms, but inflammation produced by caries, extensive excavation, or trauma to the tooth. And finally, if patient didn't go to the dentist, the pulp will be dead, clinically dead, which means non-responsive to pulp testing. And then if the patient come to the office and you try to do for him some root canal treatment and you give him intracanal medication, this will go to category of previously treated. That means you initiate the root canal treatment and the canal are obturated with various filling material other than intracanal medicament. And then previously initiated therapy. Oh, so I messed it up here. So previously initiated therapy is this one. When you do pulpectomy, and then you fill the canal with some medicament. Here, if it's not medicament, if it's like a permanent thing, which is gataperca, or if it's a primary, it will be non-sodium calcium oxide. So this one is previously treated. Previously initiated, just you did the pulpectomy, and you send him home and you booked him back. So this one is the all categories for pulp. And then we go for apical. Apical goes the same story. It will be normal apical tissue. This is not sensitive to percussion, but patient testing, everything is good. Not change in x-ray, lamina dura is intact. And then if the patient has, as we mentioned before, has caries that's going on, he might feel pain with cold stimuli, and might have a painful response to biting or a percussion or palpation. It might or might not be associated with apical radiolucent areas. So when you take x-ray for this tooth, like for example, if you did a filling which is high and the patient is biting over this filling and he feel pain, so this tooth in the x-ray maybe have some radiolucency related to the apex or nothing at all. And then if patient didn't go with the same story, asymptomatic apical periodontitis, he will have apical reducent area that does not produce clinical symptoms. So for this category, symptomatic, as you can think about it, symptomatic patient will tell you some symptoms, and the X-ray might or might not have some radiolucency. In asymptomatic, patient might not tell you anything. He might tell you, I feel the tooth is different, it's coming out of socket. I had pain in this tooth before, and now nothing is hurting me, but I would like to check upon this tooth. So, and when you take X-ray, there is apical radiolucency that not produce clinical symptoms. And then if the patient didn't go to the dentist and the issues escalate more and more, and the pulp became dead and the pulp necrose. This necrosis for the pulp can lead to acute apical abscess or chronic apical abscess, depending on the patient defense mechanism and the infection he has before. It's a multifactorial stuff, but the key point here, acute apical abscess will be having rapid onset, spontaneous pain, tenderness of tooth to pressure, pus formation, and swelling of associated tissues. So it's a story building up. Rapid onset, spontaneous pain, and then like not facial swelling, at least buccal swelling. Chronic apical abscess, it will be gradual onset, little although or no discomfort, and the intermediate discharge of pus through an associated sinus tract. So the patient, he will tell you, I had been here, it was swollen or not. It's different from one patient to another, but when you go to his mouth and you do your clinical exam, you see pus coming by pushing with your finger on the buccal side, or might see a sinus tract. Last thing is condensing osteitis. This is like different, depend on the patient defense mechanism, but usually this happen with teenager for lower posterior teeth. You will see localized bony reaction to a low-grade inflammatory stimulus, usually seen at the apex of each tooth. So this is like not very common, but might happen. So with that all said, so let's now go for the pulp therapy for primary and immature permanent teeth. So now we are going to categorize every tooth based on two main criteria. First one, the tooth is primary or permanent, immature or mature. And then the second part, the clinical signs and symptoms, which we gonna make the diagnosis upon that. Based on these two factors, then we can decide the treatment. So we make sure that we have the correct diagnosis, and then we can give the best treatment for the patient. But first thing to be said, the primary goal of pulp therapy is to maintain the integrity and health of the teeth. Not the primary goal is just to do root canal treatment. No, pulp preservation is a primary goal for treatment of a young permanent dentition. So let's go again here. He speak about the stuff we mentioned before. For every patient, comprehensive medical history should be done, and previous and present dental history should be done. This has been said more than once, so I think you know it by now. And then we're gonna speak about this is the first factor. If the tooth has reversible pulpitis and are candidate of vital pulp therapy, or irreversible pulpitis or necrosis and candidate for non-vital pulp treatment. So the vital one, which is reversible, as we mentioned in the previous 2 minutes, these accepting provoked pain of short duration, relieved with over-the-counter analgesics by brushing or upon the removal of the stimulus. Why I'm saying the exact words? Because you might see the exact words on the question, so pay attention to the exact wording. Or if it's irreversible, the patient has a history of spontaneous unprovoked pain, sinus tract, soft tissue inflammation not resulting from gingivitis or periodontitis, excessive mobility not associated with trauma or exfoliation, forcation apical radiolucency, or radiographic evidence of internal external resorption. So if you have these items, you think, okay, this is irreversible pulpitis. Irreversible pulpitis is contraindication for vital pulp therapy. It will be indication for regenerative endodontics, may be considered for immature permanent teeth with apical periodontitis or necrotic pulp and immature apex. Okay, so let's go for the scenario. Go think about the scenario one by one and giving the solution for everything. Okay, radiographic of primary tooth pulpotomy should be obtained immediately following the procedure. Why this? This can be document the quality of the fill and help determine the tooth's prognosis. So if you are going to do pulpotomy or pulpectomy, you should take X-ray, and here is the answer for this one. Use of rubber dam is considered a gold standard for pulp treatment. We said before the root canal treatment, rubber dam is a must. For this one, considering the patient age and like how he gonna be cooperating with you, so it's a gold standard here. Okay, so we speak about the second factor now. It's a primary teeth or permanent teeth. So first scenario, vital with a primary. So first thing you might think about it, protective liner. So if the cavity is big and the caries is reaching up to inner half of dentin, so you might give a protective liner, maybe placed in the deep areas of the preparation to minimize injury to the pulp, promote pulp tissue healing, and or minimize post-operative sensitivity. Why we aim for this? Again, to preserve the tooth's vitality, promote pulp tissue healing and tertiary dentin formation, and minimize bacterial micro leakage. So this is the first line we're gonna use, considering, as for sure we mentioned before, it's a vital tooth. It's within the category of reversible pulpitis. Second part, it will be indirect pulp capping, and in short, it will be IPT for this one. So remember this one, we're gonna say it a lot more than once in this article. So in this line of treatment, we leaves the deepest caries adjacent to the pulp undisturbed in an effort to avoid a pulp exposure. This caries affected dentin is covered with a biocompatible material to produce a biological seal. Meaning, like, we're gonna leave the deepest part of the caries, which will be, as we mentioned before, I speak in the different article, it will be hard and discolored, which means it's curious, but like it's hard, which means it's affected, not infected. And this one, we're gonna we speak about this before, and we say there's not article, RCT study done for this one, and saying it has a better prognosis if you have the option to do pulpotomy or indirect pulp capping, because like the indication for both line of treatment is the same. So if you have a tooth with reversible pulpitis, you can do this line of treatment or that, but the studies showed like indirect pulp capping is more preferable and has prognosis much way better from the other one, and it's in line with the golden standard here. As we said before, the line of treatment for RCT, for root canal here, to preserve the pulp vitality, is not to kill the pulp and put getaperca inside. Okay, the most important factor for this line of treatment, the tooth then is restored with a material that seals the tooth from micro leakage. This is extremely important. Okay, and then as long as the tooth remains sealed from bacterial contamination, the prognosis is good for caries to arrest and reparative dentin to form to protect the pulp. Okay, and then he speak about this one. He mentioned here. So indirect pulp treatment has been shown to have higher success rate than direct pulp capping and pulpotomy in long-term studies. IPT also allow for a normal exfoliation time. IPT can be chosen instead of direct pulp capping or pulpotomy when the pulp is normal or has a diagnosis of reversible pulpitis and there is no pulp exposure. Restorative material should seal completely the involved dentin from the oral environment. And one more factor here that you need to consider, and strictly consider this one, and this is from normal knowledge about the operative filling material. So the caries along the DEJ should be removed. You don't say, okay, this is hard discolored, I'm gonna leave it. No, caries in the anterior enamel junction should be removed regardless anything. You're doing RCT, you're doing normal operative treatment, anything, this one should be removed. And I think you know the reason why we do this, okay? And then direct pulp cap. Direct pulp cap is going to be done for the tooth, which is, and this is was surprising for me, honestly, because he considered direct pulp capping to be a form of vital pulp therapy. Like you're going to put a material inside the pulp and you think it's a vital pulp treatment. Why that? Because we're gonna do this line of treatment if the tooth is within the category of reversible pulpitis. If it goes different categories, we cannot do this. As he mentioned here, clearly a normal pulp following a small 1 millimeter or less pulp exposure of when condition for a favorable response are optimal. And this is a little tricky, so let me give you some scenarios which mean this fancy word, favorable response are optimal. So if the question mentioned like patient had a trauma and then he a trauma in his upper anterior teeth, and he is like 8 years old. So the age is extremely important because age will give you if the tooth is mature or immature. So 8 years old, most commonly this one will have open apex, and he come to you, look in his mouth after you doing the regular treatment before we see medical history stuff like this, and you see exposed pulp, which is pinpoint or 1 millimeter or 0.5 millimeter, and the instance happened like now, like maybe half an hour ago or 1 hour ago. So in this, with this all being said, so direct pulp capping is a line of treatment for this one. Or if a dentist is doing cleaning for a tooth lower six, and this lower six he was trying to dig deep, and this dentist is going by the book, and he has a rubber dam in place, and while he was doing it, he's accidentally exposed the pulp, like by his handpiece or by excavator. So in this circumstances, providing the tooth is have a normal response, or at least the tooth has the maximum the tooth has is a reversible pulpitis. In this case, you might use direct pulp capping for the treatment of this tooth. I know these two scenarios are weird, but like you might find them. No one knows. Okay. And then like we speak about this one, and then we speak about pulpotomy. When we are going to do pulpotomy, as we said, pulpotomy is preferred in a primary tooth when performed in a primary tooth when caries removal result in pulp exposure in a tooth with normal pulp or reversible pulpitis again. Okay, pulpotomy is a procedure where the coronal pulp is amputated, pulpal hemorrhage is controlled, and this is tricky because like what is the cutoff to control the pulpal hemorrhage? So the guidelines speak about like it's few minutes. So if a question saying, okay, you decided to pulpotomy and you remove the pulp tissue in the coronal part, and you try to control the hemorrhage with MTA or pharmaquizole. You try to control the hemorrhage with these two materials, and after 5 minutes, bleeding is still coming out. What you're gonna do with this one? So you have a wrong diagnosis for this tooth. This one is indicated for pulpectomy because this criteria, this clinical science you see now in the tooth now, indicating it has irreversible pulpitis. It's not irreversible pulpitis. Okay, so I wanna give you the scenarios because like if I'm going to read the article, it will be so dull. So when you read it, I know the stuff, but when you are faced with the scenarios, so you think, okay, this scenario now, this question which was before is like, what is this? This makes sense now. Okay, recommendation is to use MTA or pharmaquizole if the tooth is going to stand more than 24 months, and then the other material can be used, but like it's a conditional recommendation, not the golden standard. Okay, and then recommended, then this saying like calcium hydroxide is contraindicated to be used in pulpotomy. Why is that? Because like they found in several studies like calcium hydroxide may initiate internal root resorption inside the tooth after maybe 6 or 12 months. So they said, okay, let's not use it. The tooth is restored with a restoration that seals the tooth from micro leakage, and you can see this line again and again and again with everything. And as we mentioned before, status C crown is restoration of stories. So every time I'm saying, we're gonna say, as we said before, this is in the two articles we speak about before in the treatment for trauma, stuff like this. If you are confused now, I think you can go back to the two articles and you can see this stuff again. Okay, so indication for pulpotomy that we said before, and there is like key point here, the tooth should be vital without suppuration, purulence, necrosis, or excessive hemorrhage that cannot be controlled by a cotton pellet after several minutes. Excessive hemorrhage that cannot be controlled by a cotton pellet after several minutes. Please pay attention to these scenarios. Okay, so we finished with the vital pulp. So we're gonna go now for non-vital pulp treatment for primary teeth diagnosed with irreversible pulpitis or necrotic. First one is pulpectomy, not pulpotomy. The root canal are deprived and shaped with hand or rotary files and then irrigated. And for sure, you should make sure irrigation will not go beyond the apex. You're gonna use 1 to 5% sodium hypochlorite or sterile water or saline to be used in this one. We're gonna speak about this instance of sodium hypochlorite going from the apex it need to be discussed in different articles. And then a recent systematic review reports that zinc oxide eugenol performed better long term than a uniform based paste. So as we mentioned before in the other one, formicurozole, all MTA to be used to control hemorrhage, and in pulpectomy, the material to be used is zinc oxide eugenol is more than a uniform based paste. Okay, and then if you have the question with two answers, so you know now which answer to be chosen. So pulpectomy is indicated with irreversible pulpitis, necrosis, or tooth treatment plan for pulpectomy in which a radicular pulp exhibit clinical signs of irreversible pulpitis or pulp necrosis. As we said before, you cannot control the bleeding after a few minutes. And then there is some like fancy stuff they should mention in every article. Lesion, sterilization, tissue repair. Like you remember the HAL technique we speak about before, it's something like this. There is no instrumentation to be used inside the root canal. Instead, antibiotic mixture is placed inside the pulp chamber. The wall of the chamber are cleaned with phosphoric acid and then rinsed and dry. 3 antibiotic mixture, clinda, metronidazole, and ciprofloxacin is combined with a liquid vector of polyethylene glycol to macrogel to form a paste placed directly into the medication receptacle and over the pulpar floor. So to cut it short, you clean the pulp chamber and you will not touch the root canal itself with files or anything. You're gonna mix this 3 antibiotics together and put it inside. It then covered with a glass iomer cement and restored with a stainless steel crown. As we mentioned before, this is a guideline for everything. So and then he speak about that why he chose this 3 mixture of antibiotics. So as we know, clindamycin, metronidazole, and ciprofloxacin usually they have broad spectrum for, if you mix it together, they will have broad spectrum against gram-negative bacteria and also gram-positive bacteria, and clindamycin is more to anaerobic bacteria. So they found out this mixture were gonna be very beneficial to kill the bacteria inside it. So, and he said like mixture should not include tetracycline. I think you can understand why we should not include tetracycline in this mixture. For the pigmentation, for sure. I hope you get the answers. Okay. So we said we're gonna use this treatment for the same indication of irreversible pulpitis. We can use it even with pus, with everything. You can use this one. Okay. So and this wrap off everything for the primary teeth. I hope that was beneficial for you and you have your notes now. So if you are confusing about anything, you just can go back to the video and dig it deep again and look again, here again, get your notes again, okay? So then we're gonna speak about immature permanent teeth and we're gonna speak about the 2 factors, is it vital or non-vital? Again, it's the same story, I'm not going to repeat it again, a protective liner to be used, okay? To place a liner in deep area to protect the pulp. Or we can aim for apexogenesis. So apexogenesis is a term, it's not a treatment. What this mean? This mean like apexogenesis is like, think about it, it's a category, has more than 1 line of treatment. What are the line of treatment inside this apexogenesis? Genesis mean like formation, apex. So we are aiming to do root formation. We are aiming to continue with physiological, developmental, and formation of the root apex. We want the root to be longer and form its apex. In this category, we have line of treatment, which is including indirect pulp capping, direct pulp capping, partial pulpotomy for carious exposure, and traumatic exposure. So I think you're confused now. So let's go part by part and then mix it together and get everything inside the category of apexogenesis. For sure, as we said, indirect pulp capping and direct pulp capping or partial pulpotomy. So I think you can understand it now. This indicated only for vital tooth, which is normal pulp or has reversible pulpitis. If he didn't sleep yesterday, if the over-the-counter medication is not working, so it's contraindicated for apexogenesis. In recent year, rather than completing the carious removal in 2 appointments, the focus has been to excavate as close as possible to the pulp, place a protective liner, as we mentioned in the previous part, and restore the tooth without a subsequent re-entry to remove any remaining affected dentin. So it's just 1 step. You remove everything, leave the affected, hard, discolored dentin inside, use a protective liner, and then do your treatment, fill the tooth, and the most important factor is a well-sealed restoration. The first step is the removal of carious dentin along the dentin enamel. This is the point I mentioned before. The dentin enamel junction and excavation of the outermost infected dentin, leaving a carious mass. Before they used to do a second step. Second step is the removal of the remaining caries and placement of final restoration, and they found that it's not mandatory to do this again. As long as the tooth is well sealed, it's good. You can just leave it. Okay, what if you have exposure? So you're going to go to direct pulp cap, and we speak about this before. Small caries or mechanical exposure in a tooth with a normal bulb, you can do direct pulp capping. And partial pulpotomy for caries exposure. And this is limited line of treatment and it has specific condition. You should think about it. So this one, the inflamed pulp tissue beneath an exposure is removed to a depth of 1 to 3 millimeter or a deeper to reach a healthy pulp tissue. So you are not going to remove the whole soft tissue inside the pulp chamber. You're gonna move 2 or 3 millimeter till the bleeding is good. Pulp bleeding must be controlled by irrigation with a bactericidal agent such as sodium hypochlorite or chlorhexidine before the site is covered with calcium hydroxide or MTA. So partial pulpotomy if you have caries exposure, not iatrogenic exposure. Iatrogenic means like it's a dentist's fault. So don't mix it together. Direct pulp capping is indicated if the tooth has a trauma with little pinpoint exposure, or the dentist was dealing with a tooth and then he did it by mistake. By mistake meaning there was no caries over the pulp. But if you have caries over the bulb, so but for sure it's still within the category of reverse pulpitis, so you can aim for partial pulpotomy. So I think now you can tell the difference. The difference for the first scenario, it was with rubber dam, everything was perfect, you were just removing and then by mistake you make exposure. In the second one, partial pulpotomy, no, you have caries that you were trying to remove, and then while you're removing the caries, you still see soft tissue, soft dentin, you still see discoloration, which is not hard. While you were doing this, you reach into the pulp. In this case, you do partial pulpotomy, not direct pulp cap. I hope this is clear now because it's confusing for some people. MTA result in more predictable dentin bridging and pulp health. MTA at least 1.5 millimeter thick should cover the exposure and surrounding dentin, followed by a layer of a light cured resin, modified glass ionomer restoration that seal the tooth from micro leakage is placed. I see. I believe now you see the pattern. This line is important. This line is important beside the other line, speaking about the removing of everything, discolored caries, everything you see in the anterior enamel junction. Okay? And then the remaining pulp should continue to be vital after partial pulpotomy, and there should be no adverse clinical signs and symptoms. We speak about this before, and we said like you should tell the parents or the patient himself about what he will anticipate in the next few days and what is normal within normal range and what is not normal, and he should come back to your office. And then it's the same line of treatment, partial pulpotomy, but like for traumatic exposure. I think there is a dentist, he's called with Shivak, and he was like, okay, well, you can use this one for the trauma also. And he mentioned, and he insists to put his name over this line of treatment. So it's the same everything, but the line of treatment is indicated for the trauma, not inside the clinic while you're removing the caries. And then the bleeding should be controlled using irrigant as sodium hypochlorite or chlorhexidine. And then you're going to use MTA at least 1.5. It's the same story, everything. Okay? And complete pulpotomy. When you are going to complete pulpotomy, it's the same indication, same scenario. You remove 2 or 3 millimeter and it's still bleeding. So you're going to remove everything inside the pulp chamber. MTA and tricalcium silicate exhibit superior long-term seal and reparative dentin formation, leading to a higher success rate. So I think now we used to know like the calcium oxide is a golden standard, but now we can see there is emerging evidence that MTA is more favorable. But the problem with MTA, it has prolonged setting time. I think you know this. MTA will be completely set maybe 24 hours or more than 24 hours. So at least 1.5 millimeter thick should be applied to like give some strength for the material that is completely set. But the study is showing amazing result for the MTA. Full pulpotomy procedure in a vital permanent tooth aim to preserve the vitality of the remaining articular pulp. what this line means. This line means, you remember the patient we speak about him before, he has a trauma for the anterior teeth. So if he comes to your office and he's not 9 years old, he's not 8 years old, he's 25 years old. So this tooth is like permanent. This tooth has closed apex. As we mentioned in the beginning of the articles, the preserve pulp vitality is the golden standard, is our goal, is our rationale about the root canal treatment here. So providing the tooth is within the normal pulp to reverse pulpitis, you can do partial pulpotomy for this tooth. If you cannot do partial pulpotomy, you can do complete pulpotomy for this tooth. It's not like, okay, the exposure, let's jump into root canal treatment. No, you can give the tooth a chance, and then you give the patient the knowledge about what he will anticipate if he has something is not good with him. So he come back and then you initiate root canal treatment. Because this scenario is weird, honestly, but like it's mentioned here, like completely obvious. You can read again at your convenience. Okay. And then obtaining radiograph evidence is good after you do pulpotomy. We mentioned this before. And then we said like what you anticipate from here. You are not a magician. You will not anticipate the tooth. He come to you after 1 year, 2 years, no pain, no signs of discoloration, nothing. And you do pulp testing and it's negative pulp testing. But you do x-ray and you compare it before x-ray. You see the root is developing. You see the apex is forming, is closing, and the dentin inside the tooth itself is growing up. The pulp size is decreasing in size. The pulp shape itself, the reducent line inside the root is decreasing in size, meaning the dentin is forming inside the tooth. And you say, okay, because it's not responding to the pulp vitality test, I would do root canal treatment. No, it's good enough. As long as the dentin is good, the apex is forming, it's good enough. You just leave it, okay? And then non-vital treatment. Non-vital treatment is pulpectomy, as we mentioned before when we go pulpectomy. If you have irreversible pulpitis or you choose to do pulpotomy, but you cannot control the bleeding. So this 3 line of treatments is under the category of epixogenesis. So what if you are faced with the same scenario, immature apex, but the tooth has irreversible pulpitis. The tooth has necrosis. The tooth has more severe signs and symptoms. So you cannot say, okay, let's hope for peace and do pulpotomy or direct pulp capping, stuff like this. This will contraindicate the whole category of genesis, epixogenesis. Now we are aiming to preserve the tooth itself. It's not the vitality. It's the tooth itself, which we're gonna use epixification, root end closure, is by inducing root end closure of an incompletely formed non-vital permanent tooth by removing the coronal and non-vital radicular tissue just short of the root ends and place a biocompatible agent such as calcium hydroxide in the canal for 2 weeks to 1 month to disinfect the canal space. So you say, okay, this tooth is non-vital or this tooth has irreversible pulpitis, so epixogenesis is contraindicated. What you are going to do now to remove everything, and then you put calcium hydroxide for 2 months or 2 weeks up to 1 month. And then the patient will come back to you. And then you're going to make a barrier by yourself using apical barriers such as MTA. So you're going to use MTA and plug it inside the apex. For sure, you take x-ray, you take the working length, and you go 2 millimeter shorting by the working length, and you put MTA. Okay, so if you think about it from the clinical perspective, you might think, okay, but what if the apex is open, large? Because this has a specific instrument, it's like condenser, but like specific sizes, and you go to like push the MTA. So if the apex is very big, so you're gonna use our absorbable collagen wand dressing can be placed at the root end to allow MTA to be packed within the confines of the canal space. This is too much to be said honestly for AFK, but like I don't want you to read stuff in the article. You say, okay, discard it. I will not think about it. No, everything you read in the article, anything is not very clear, you can ask me. I will gladly explain it to you. But this is the clinical criteria you should be looking for. Okay, and filled with MTA or composite resin instead of gutta-perca to strengthen the tooth against the fracture. In this case, when the apex is largely open, meaning the dentin is so thin in this area, so they prefer to use MTA, but this is a very rich dentist to fill the whole canal with MTA, or a composite resin, still is very rich. And then to strengthen the tooth against fracture. Okay? The procedure should induce root end closure. You are not aiming for genesis. You're aiming for apexification at the apexes of immature or result in an apical barrier as confirmed by clinical and radiographic evaluation. Adverse post-treatment clinical signs or symptoms of sensitivity, pain, swelling should not be evident. If this happens, so you didn't do an amazing job here. And lastly, as we mentioned before, NDB should every time bring a fancy term in the end of every article. Regenerative endodontic treatment. What this mean? This mean like you are aiming to be the magician here, not only the dentist. So the tooth is non-vital or necrotic or have signs and symptoms. You cannot do apexigenesis and you're aiming for apexification. But you want to do it again to like regenerate the vital bulb tissue inside. Is defined as biologically based procedure designed to physiologically replace damaged root structure, including dentin and root structure, as well as the bulb dentin complex. Told you it's sophisticated. So let's say it in a simple term. In a simple term, the goal are elimination of clinical symptoms, signs, and resolution of the apical periodontitis in a teeth with a necrotic pulp and immature apex. Still sophisticated. Thickening of the canal wall and or containment root maturation is an additional goal. So in regenerative endodontic treatment, we are aiming to regenerate the soft tissue inside the canal. If we manage to do this, if by any means we can do this, so we'll anticipate a thickening of the canal and containment root maturation, but this is an additional goal. It's not like a primary goal here. The primary goal here to the resolution of apical periodontitis and necrotic pulp and immature apex. This term is the former therapy is filled with the host's own vital tissue, and the canal space in the later therapy is filled with biocompatible foreign materials. Oh man, like this is even sophisticated for me to read for the 100th time now. So the difference here, he speaks to you again. Regenerative endodontic treatment, you are aiming to fill the tooth from inside by a soft tissue from the patient himself. And the other one, you are aiming to use a biocompatible foreign material to fill it. So apexification versus apexigenesis versus regenerative apexification, you are using MTA, you are using composite or gutta-perca to fill the inside the root. Here, no, he is aiming to induce bleeding inside the canal, which is sterile now after eliminating everything, and he's aiming to get some soft tissue inside the root itself. Okay, to cut it short for you, the tooth should continue to erupt and the alveolus should continue to grow in conjunction with the adjacent tooth. So before we said for apexification, the main goal here is to see thickening, but he mentioned here thickening is like additional goal. So for regeneration, we have two goals. First, resolution of the inflammation, clinical signs and symptoms, and apical periodontitis, and X-ray signs and symptoms. And second, the tooth should continue to erupt and the alveolus should continue to grow in conjunction with adjacent teeth. So if you didn't manage to reach these two goals, so you can call your treatment doomed. It's failure now. It's not good for this patient. Okay, I hope this was beneficial for you. And again, feel free to leave a comment, to share this video with other dentists going to the exam, and have a good day.